Welcome to the Center for Global Development. My name is Javier Guzman. I'm the Director of Global Health, and it's a pleasure for me to welcome you all today to an event that will go through the current state and the future of COVID-19 antivirals, COVID-19 treatments. As you all know, innovation has been at the center of the response to the COVID-19 pandemic. We've had new vaccines, new diagnostics, new therapeutics, including oral antivirals in record time. However, the benefits associated with those new products have not been shared equally. And unfortunately, in low-income countries, we still don't have access to those essential products. Vaccines, for instance, only 25% of people in low-income countries have their first dose. And with oral antivirals, the access has been concentrated on high-income countries. Interestingly enough, oral antivirals do have certain features that are, interesting and important in comparison to vaccines. So we have, something that's easier to manufacture. We have licensing agreements. We have manufacturers from low and middle income countries. We don't need cold chain. So today we're going to talk about all these issues related to the supply and the demand of oral antivirals. First, we're going to have a short presentation from my colleagues, Janine Martin-Keller, Deputy Director of Global Health Policy and Policy Fellow, and Morgan Pinkham, Program Coordinator within the Global Health team. Then we'll move to a panel discussion, and we will welcome your questions. And then we'll close with the key takeaways from this conversation. So thank you very much for joining again. And over to you, Janine.
Great. Thank you so much, Javier. And hello, everyone. Now my colleague Morgan and I will share a few framing thoughts, drawing on some recent work we've done here at the Center for Global Development, very much with the goal of helping to set the scene for the great panel discussion that will follow. Next slide. So I'm going to start off just by talking a little bit about the big picture. I'll share some key milestones we've seen so far over the past year or so related to the development, the authorization, and deployment of oral antiviral treatments. Just to say, this is very much not meant to be a comprehensive timeline. I'm really just going to highlight a couple of top line features to help contextualize today's conversation. Next slide. So let's start with looking at the authorization of new oral antiviral treatments. So perhaps most significantly, as many of you will recall, at the end of 2021, we saw two drugs, Paxlovid, developed by Pfizer, and Lagevrio, developed by Merck, receive emergency use authorization from the US FDA. This was shortly following promising clinical trial results. In the case of Paxlovid specifically, the trial results showed that it reduced the risk of hospitalization by 89%, with many calling it a potential game changer for the future course of the pandemic. Following this, in the first few months of 2022, the WHO recommended use of both pills. In the case of Paxlovid, WHO concluded that it was the best therapeutic choice for high-risk individuals. I should also add that late last year, we saw a third treatment receive emergency use approval, this time in Japan. This is a homegrown antiviral treatment called Zecova. Next slide. But of course, getting these treatments authorized is only one prerequisite. Now comes the important steps of actually getting these treatments to everyone around the world that needs them. And in this regard, we saw both Pfizer and Merck take encouraging steps, as Javier alluded to earlier. In late 2021, Merck and Pfizer signed agreements with the UN-backed Medicines Patent Pool to voluntarily license generic companies to produce their drugs that would help bring these treatments to about 100 low and middle income countries. We've also since then seen 3 generic products receive WHO pre-qualification. One generic version of Paxlovid, and 2 generic versions of Merck's drug, Lagevrio. Following this, we also saw several supply agreements and pricing agreements. Pfizer, for example, announced plans to make Paxlovid available to global agencies like UNICEF and the Global Fund. We've also seen pricing agreements with the generic manufacturers to help keep the price of generic versions of Paxlovid low for low and middle income countries. And finally, we've seen partners like USAID, the Global Fund, Unitaid, as well as a consortium known as the Quick Start Consortium, stand up test to treat programs to begin to build the infrastructure that's needed to actually get these pills out to patients in several countries in Africa and Southeast Asia. Next slide. So it's been more than a year, and where do things currently stand? As Javier mentioned earlier, despite promising results, despite WHO's recommendations, access, especially to Paxlovid, for the most part, remains concentrated in wealthier countries. High-risk individuals who live outside of these wealthier countries really don't have access to a treatment like Paxlovid. In large part, the situation is explained by the fact that wealthier countries essentially pre-purchased a majority of the initial supply of these new drugs. And the figure on the chart shows exactly that. You can see the larger, longer bars for high-income countries at the very top of the figure that indicated that these high-income countries are the ones that, for the most part, purchased these treatments. But I'd say that alongside this trend, there's also another reality, which is that demand for treatments like Paxlovid in lower-income country contexts remains extremely low. Next slide. Of course, all of these supply and demand dynamics are existing within the wider trajectory of the COVID-19 pandemic. And we've seen both cases and deaths generally trend downwards over the last several months. Of course, as you can see this in the chart, this is with the exception of the recent spike we saw in China. And for the most part, countries around the world are really moving towards managing COVID as an endemic disease. Beyond this, health systems are still recovering from the aftershocks of the pandemic. Many of them are facing many demands far beyond COVID-19 for limited resources. Beyond health, we're also seeing lots of other issues vying for policymakers' attention. We're witnessing a global economic slowdown. Countries are facing mounting debt, high inflation, historic levels of food insecurity. And as a result, governments are facing a lot of pressures on their budgets. With budgets being tight, this means that these kinds of treatments, oral antiviral pills, are essentially competing for scarce resources, not just with other COVID-19 medical countermeasures, but also with other health products and broader other priorities within the broader health system as well. Next slide. Now I'll hand over to my colleague, Morgan.
Thanks, Janine. So in addition to this shifting landscape, demand remains very low for these COVID-19 treatments, especially in lower income countries, as Janine alluded to. We at CGD have been looking at 5 key interlinked factors that go a long way in explaining the issue. First, there's limited data on the clinical efficacy of COVID-19 treatments against dominant variants and effectiveness in real-world scenarios. The evidence that's currently available is mainly based on clinical trials with controlled conditions in high-income countries that were conducted before the Omicron wave. Policymakers, providers, and patients also have concerns about the risk of rebound cases and drug interactions. In addition, uncertainty and unfavorable perceptions about the benefits and costs of oral antivirals, including their distribution and delivery, raise important questions about whether these treatments provide the best value for money compared to other COVID-19 interventions, including vaccination. Compounded by a lack of representative COVID-19 testing data, it's difficult to assess the real burden of disease associated with COVID, and therefore whether to prioritize spending on treatments, especially given the current pressures on health budgets. Second, despite the voluntary license deals signed for these treatments through the medicines patent pool, high-quality generic products are not yet available, signaling potential challenges with the agreements. For example, Medicines Patent Pool issued an unprecedented volume of licenses to produce generic versions of Paxlovid and Lagevrio. Although a large number of manufacturers can support an efficient ramp-up of generic production, Too many manufacturers can create problems by limiting returns and financial viability for companies. In addition, voluntary licensing agreements require that generic manufacturers achieve regulatory approval from the World Health Organization's pre-qualification program or from a stringent regulatory authority. In the absence of an alternative pathway through a stringent regulatory authority, the regulatory approval process for all generic oral antivirals is currently fully centralized within WHO's pre-qualification program, which is already stretched thin. In the case of the MPP deals with Pfizer and Merck, about half of licensees have no prior experience with voluntary licensing, as you can see on the right. And about half also have not achieved WHO pre-qualification status before. Delays in access to generic products are likely, since regulatory pathways are overburdened and as many licensees learn the ropes. Third, in part due to the lack of lower cost generic versions, treatments are still prohibitively expensive in many contexts. Pricing and procurement agreements have been signed to expand access in the shorter term, but details, including pricing specifics, are often not transparent, which limits the impact on decision-making calculus for purchasers. Negotiated pricing agreements with generic manufacturers, such as the deal the Clinton Health Access Initiative negotiated with suppliers last year to provide generic Paxlovid in lower-income countries for under $25 per treatment course, are an encouraging step, especially compared to the more than $500 price that some wealthier countries paid. But still, these lower prices depend on minimum volume requirements, exclude delivery costs, and still represent a significant cost in many contexts. For example, as you can see in the chart, this cost exceeds total health expenditure per person per year in the Democratic Republic of the Congo, and is equivalent to about 50% of health spending per person per year in countries like Bangladesh and Rwanda. Fourth, uncertain future demand for COVID-19 treatments can pose obstacles to production scale-up and capacity maintenance. Little to no visibility into current and future pipelines for oral antivirals weakens incentives for generic manufacturers, some of whom may adopt a wait-and-see approach and defer filing for regulatory approval. Accurate demand forecasting is extremely challenging in the face of multiple epidemiological and policy uncertainties. Estimates depend on timely tracking of COVID caseloads via testing to assess potential clinical need, and must also account for additional factors related to regulatory guidance, country priorities, rapid test availability and turnaround, and other policy considerations. This data is complex and often not available or representative. As seen in this chart, which includes forecasted demand for oral antivirals in low and middle income countries for 2022 from the Clinton Health Access Initiative, modeling is based on several scenarios, which are often based on a series of assumptions in which there are varying degrees of confidence. As a result, across these scenarios, estimates have a wide range from 3.1 million to 14.8 million treatment courses, which drives home the difficulty in generating these estimates. And finally, the fifth point, efficient deployment infrastructure is critical for an effective global rollout of COVID treatments. These medicines must be taken in a tight window after symptom onset. However, there are few resources available to develop the appropriate test-to-treat infrastructure. There have been several encouraging efforts to implement test-to-treat infrastructure in the past few months, as Janine mentioned earlier, and which the panel can speak to more in a bit. But more remains to be done to evaluate these initiatives, consider the economic and clinical rationale for deploying test-to-treat strategies amid other COVID-19 response strategies, global health security considerations, and essential health priorities, and to leverage underutilized strategies and infrastructure for deployment, including those in the private sector, which accounts for as much as 80% of health product purchases in low and middle income country contexts. And with that, I'll pass back to Janine to conclude.
So all of these factors that Morgan walked us through might suggest that it's time to revisit our approach. As I mentioned earlier, while Paxlovid was initially seen as a game changer, more than a year later, it might be time to adapt our approach and ask, should oral antivirals still be a priority in low and middle income country context? Just to note, though, that in the event that there is a dangerous new variant that emerges, getting these treatments out in an equitable way and extremely quickly to countries around the world, especially to high-risk individuals, could be quite important. So there could be, for example, a role for a stockpile, either held at the global level or held within regional hubs around the world, that could provide an important policy safeguard. With that, I'll stop there and hand back to my colleague, Javier, to lead us to the panel discussion. Thank you.
Thank you very much, Janine and Morgan, and thank you for doing this stock-taking exercise, I'm talking about the 5 lacks: the lack of data, the lack of supply, the lack of affordability, the lack of visibility of demand, and the lack of infrastructure. Now we're moving to the panel, but before I introduce our distinguished panelists, I just want to remind our audience that we are basically streaming in French and in English, and that you can, send your questions via Twitter, LinkedIn, and YouTube. So we have the pleasure to host 3 distinguished speakers, panelists today. First, we have Dr. Serge Paul Eholier, who is Professor of Infectious and Tropical Diseases at the Treville University Teaching Hospital. We also have Carol Holtman, Senior COVID Technical Advisor at USAID. And we have David Rippin, Executive Vice President of Infectious Diseases and Chief Science Officer at the Clinton Health Access Initiative. And they all come from different perspectives. They all have different vantage points. So it'll be a great conversation. And the first question I have for you 3 is, we've heard from Janine and from Morgan, where we are. You also know it hasn't been easy to come to this point. Do you think that the deployment of oral antivirals should still be a priority for lower income countries? And what do you think is the role those oral antivirals should play as COVID-19 becomes an endemic disease? Dr. Serge, do you want to start? Welcome.
Oui, merci beaucoup. Bonjour, je suis professeur Eholier Serge, chef du service des maladies infectieuses à Abidjan.
Chief of the infectious diseases in Abidjan, Ivory Coast. I believe that the presentation that was made was very clear and accurate. The impression I keep is that at the time where we should have had those antiviral at the time of vaccination, with peaks of COVID diseases and infection. When we look at the WHO info for African countries, I can't talk about other countries, we can see that in most of the Western, even Central African countries, we don't have any COVID cases. No, it's not that we don't see any. There are some. We have gone from epidemic to endemic, even sporadic, and we see isolated cases. But some countries don't have any tracing and testing. Don't forget that COVID was associated with free testing. Tests were paid, given by partners for development, technical and financial partners, and now reactives are for their states. And reactives have been interrupted. The tests today are not performed anymore in certain countries, and I would say even in the majority of countries. We are at a point where it bothers me a little bit to say it, but there is a banalization of the epidemic, and we have individual responsibility towards this disease. So some individuals get tested, they have auto tests. They don't even come to the hospital to use the medicine because they say that anyway, it's not a serious disease. They are not afraid of it anymore. At the time, they would go directly to the hospital, not anymore. We don't have an idea anymore of the seriousness and number of cases. It's not even seasonal anymore. And number 2, there is a preemption issue as well. And there's a cost for these medicine. So if we have medicine easy to prescribe, we heard in the presentation, there are some criteria of prescription of these molecules early, within 5 days, with criteria of age, comorbidity, which means that the prescription is limited in a country such as ours, even in Africa, where 70% of the population is less than 35 years old. Only 10% of the population is 65 or over, so it's very delicate to prescribe. As for generic molecular in Ivory Coast, now I'm not sure we should have it. We should have it, but I don't know how we're going to proceed with the potential of epidemic disease. That was my initial comment I wanted to convey.
Thank you very much, Dr. Search. Very clear and very interesting what you said. Carol, do you want to answer the same question? I'll remind you what the question is. We're asking whether oral antivirals should still be a priority for lower-income countries, and what role do you think they should play as COVID-19 becomes an endemic disease? Over to you, Carol, and welcome to CGT.
Great. Thank you so much, Javier, and thank you for having me as part of this panel. So I'll be speaking as representative of USAID and be able to speak a bit on our experiences here at USAID. To answer your question simply, yes, absolutely. Oral antivirals should still be a priority for low-middle-income countries. I know that the cases have been the lowest since the pandemic. We still have about, still 4.5 million cases in the past month and about 35,000 deaths. And this is despite decreased testing overall. This may actually be on par with the number of deaths caused by seasonal influenza annually. I think we are, entering an endemic phase. I hope that we are. But I think it's still a lot of unknowns out there. So because of these unknowns, we could still have additional epidemic waves. Oral antivirals are still an important tool in our armamentarium for specifically vulnerable clients, right? We can't leave out our elderly population who are at high risk for severe disease. There are still populations of people who are unvaccinated, those who are immunocompromised, those with chronic conditions. They are at risk for severe disease and death. And, we can still be prepared with additional epidemic waves for these clients, prevent hospitalizations and deaths. These oral antivirals have been shown to decrease hospitalizations and deaths. And in so doing, we can help prevent strains on health systems. So that's the first point. I think the second point is that we need to continue to support countries to develop COVID test to treat strategies that can prepare them for future pandemics or epidemic threats. I think a lot of what USAID is trying to do with test to treat strategies is to establish efficient service delivery models and find ways to strengthen health systems. And in so doing, this part of what we do is, communities need to be able to identify signs and symptoms, promptly seek care, rapidly receive diagnosis and treatment. These are all critical components to controlling an epidemic and eventually, also saving lives. USAID, is working, to try to establish these programs through established health systems, preferably integrating it into primary care. So we're not trying to create any siloed or vertical programs here. We're trying to do this, integrating it into the existing health system. And this is very important for countries to figure out how we're doing this. So it's not just about COVID. It's all about other respiratory disease management, other epidemic threats that are caused by respiratory disease. Obviously, given if there are diagnosis and treatments available, but at the end of the day, we're also supporting and enabling countries to be more resilient to whatever emerging epidemic threats there are. So yes, I think it is important to still work very hard to support countries to roll out COVID oral anti-treatments for our clients and particularly our vulnerable patients. So back to you, Javier.
Thank you, Carol. Interesting perspective, not thinking about the present, but thinking about the future. We'll get down to that. David, what are your thoughts on the same question? Over to you, and welcome to CGT.
Thank you so much for the invitation. And I just want to really appreciate all of the outstanding comments which came before me, the presentation and comments from my fellow panelists. I really want to pick up where Carol left off. I mean, I think fundamentally, this is as much about primary healthcare, pandemic preparedness, AMR response, and comprehensive respiratory illness management as it is specifically about COVID. And, I also want to throw out and highlight the need for equity and parity of access across the globe. We're working in a current situation where the standard of care in the US, as an example, is the use of self-testing, which are widely available, followed by access to treatments at the pharmacy or community health worker equivalent level. And that's really what we should be working towards here. A few specific points. If we develop and have a good primary healthcare system, we are already going to know who the patients most at risk, who should be prioritized to get the COVID therapeutics are. Now, we already do have some of them in care. Our patients who are living with HIV, patients who are battling another infectious disease such as TB, those who are overweight, smoke, or are older in age. But we should be doing a better job of knowing who our most vulnerable in the population are. Ultimately, my perspective on future pandemics, and I think this is as much about responding to COVID as it is about being prepared for future pandemics, is that we need an always-on system that begins at the community level of care, that is able to rapidly adapt to a new challenge which is presented. And test and treat is the paradigm from my perspective that is that community level entry point. I want to, I suspect we'll get into these in a little bit in the panel as we talk about some of the market failures or issues that we need to address in order to, get that price down. I acknowledge that $25 for a course is still too high. But as we talk about the concept of stockpiles and the like, I think we've learned a lot from HIV treatment. If patients show up and you either turn them away without a treatment or you are not stocked to deliver them treatment, they lose faith in the health system and they don't tend to come back. We learned that when we had CD4 cutoffs for initiation of HIV treatment and how hard it's been to get some of those patients back who didn't initially qualify. Secondly, I think, for COVID therapeutics, this is as much about future waves and future variants and the threat from them as it is to current response. As we know, this pandemic is unpredictable and these waves come on quickly. For test and treat to work, we need products pre-distributed all the way down, not to central supply chain locations, but into community health worker hands in quantities sufficient for them to be able to respond if a more virulent variant comes out or we see another wave and patient care seeking increases. What does that mean? It means we're going to need donors to be willing to take a certain amount of supply risk that if those waves don't materialize, and I certainly think we hope they don't, that maybe some of that product will go to waste. But we need to accept that that's okay. This is as much about being prepared for the worst as it is about dealing with the pandemic as we have it now. Maybe I'll stop there. Looking forward to the rest of the discussion on the panel.
Thank you very much, David. Dr. Serge, we just heard from David how important test and treat systems are for response, and how with HIV some health systems learned that it was important to have medications always available. We know that Côte d'Ivoire did put in place a test and treat pilot program, and we just wanted to ask about what are your reflections on the program? Has it worked? What are the challenges? And how do you link the program to in-country demand? Have you been able to move with a better estimation of demand? Over to you, Dr. Serge, for your thoughts on the test and treat pilot program.
Thank you very much. I think that what we're saying today, we need to answer, but we need to answer it in a specific context. Because if we have a global answer, we won't be able to adapt it to the context and it won't work. So in the Côte d'Ivoire's context, we have these drugs, we have to order them. And in most countries, we are testing everywhere, and we didn't have as many cases as we did before. So when we are in the communities about primary health, they are doing so the tests every day. So what's happening? We have ordered too many tests, and when we received them, we had this decrease in cases. So people wouldn't come to the hospital anymore. Most countries started even to change their sites. So in my experience, the treatment is working correctly for those who have been prescribed this treatment. But this treatment, we have to have it available. But this endemic disease means that we will have sporadic cases. But I need to take this risk and I need to order these drugs. I need to have this stock. But I have to check with the government, because we won't be able to tell them we will wait until we have the next pandemic. So most states want to come back to a normal life, and to be able to come back to this normal life, and that's why I'm asking you to put it in context, is to come back to our previous life. For COVID, we had a lot of investment, and we have these tests that are available. The auto test that we have, for example, they sell it in different pharmacies, but they are very expensive. And the different tests we had all over are everywhere. But we need to go and check and do the test through the nose. So people are not necessarily willing to do it. So that's why it's important to put it in context. There is the person who is in charge of the national health, and he is the one that has to ask and be able to receive the drugs. So it will depend on the programs. The interpreter excuses herself, but the connection and the audio quality is not very good, and we cannot hear the speaker very well. So if they ask me, we need to have a security stock in case we still have this pandemic. We need to have this stock. So we will be able to react if the pandemic comes back. Thank you. That's it. Thank you.
Thank you, Dr. Serge. I think you just said something that really resonated with me, which is the answer needs to be context specific. And I was, very interested to hear in your first answer, the demographics and the population. You reminded us, how young the African continent is, and that might not have the same risk factors as other middle-income countries or more urban areas or high-income countries. So I do appreciate very much your point about an answer that is country specific and context specific. And also, well, what you said about the security stock, I guess you do agree fully with David that donors will need to be able to understand that there is this works like an insurance. You pay and you expect, you hope for the best, but you prepare for the worst. So with that in mind, I just wanted to invite Carol to tell us a bit about the USAID strategy in terms of COVID-19 treatments and how that has evolved. I mean, how are you responding to this low demand from low-income countries? How do you address the points made by Dr. Serge on the country-specific solutions? Over to you, Carol. Thank you.
Thank you, Javier. Yeah, so a critical component of our test to treat strategy is demand generation and community sensitization. Now, this was built into our strategy from the get-go, and not just as demand was falling as we started to implement. I can understand, political leaders and governments may not necessarily prioritize COVID due to other competing health threats. I get it. We've had, monkeypox, we've had Ebola, but if we can provide clients and communities with the correct information about how to recognize signs and symptoms, information whether they're at a particularly high risk for severe disease, where to get tested, even the fact that life-saving treatments are available and where to find them. Then I believe there will be demand for testing and treatment. I think one of the programs that we saw, some preliminary data that's coming out from our Rwanda program is that with community sensitization, nearly 100% of all our clients who presented at care came within that 5-day window of symptom onset. I think that goes to show that, getting that information out to communities and to people who are the recipients of these life-saving treatments is what's really important. And that's what we're doing here at USAID. And I think that continues to be an ongoing important strategy for our programs and for rolling out these oral antivirals. Back over to you.
Thank you, Carol. Dr. Serge, just a quick question, just to put this into perspective. How many cases do you, if you can tell us how many cases Côte d'Ivoire has, per day these days, or any numbers, so we can, wrap our head around what the situation is over there? You're muted, Dr. Serge.
Ce que je vous propose, ce n'est pas des chiffres par jour, c'est des chiffres hebdomadaires.
I won't be giving you the numbers, but I will be speaking about the last 3 weeks.
Par exemple, aujourd'hui, si me demandez, aujourd'hui, nous avons eu 7 cas dépistés.
For example, today,
la notion de communauté tout à l'heure. 7 cas dépistés, parmi ces 7 cas,
we had 7 cases tested, and out of these 7, none of them had 65 or over. Yesterday, 0. Last week, 50 cases, and 3 cases had more than 70 years. I'm speaking about cases tested outside the hospital. So we had one person, 82 years old, and even though she was hospitalized by precaution, she was okay. So when we speak with the government and we tell them that the epidemic is under control, and we tell them about 500 cases per day, that's one thing. But now we're saying 5 cases per day, which is not the same context. We're not in the same context. So when the WHO spoke about this national health, like at the global level, the emotions are not the same. So we are still doing awareness campaigns, but the people that come are not eligible. They are young, they are in a good health, they're not in a risk place. So for us, these people are not at risk. We need to see again and be sure who are we prescribing to. So again, putting everything into context, I'm able to treat people because I still have the security stock from state. So the thing is that it's not that we do not have to prescribe, but who should we prescribe to? So that's the question we have to ask ourselves. So people who are sick in an endemic disease, so this disease is endemic. We have a vaccine. And that's what I have. Thank you.
Thank you,
Mr. Guzman.
Thank you, Dr. Serge, for putting us into context and telling us about the situation in Cote d'Ivoire. David, Chai has been very instrumental in setting up, the COVID Quick Start Consortium, and you guys are on the ground supporting a lot of countries with the test and treat pilot programs. What's your overall take on the current situation? And you mentioned something in your first response about price, and we clearly know that the lack of demand might be related to the price that we currently have, the $25. Is there any sign that will change? Over to you, David, for your reflections.
Yeah, thank you. And I'll talk about our program in a moment. I just want to pick up on the themes of both community engagement and partnership to drive demand. And that can be general or it can be specific amongst communities who are highest at risk: patients who are living with HIV, patients in TB care, elderly communities, and the like. And secondly, I want to pick up on a point that Serge made around the cost of the self-tests as well. We haven't generally spoken about surveillance because surveillance is not generally focused on individual patient diagnosis and care. But if we have a system where we can pre-distribute self-tests to individuals who we already know to be at high risk, patients in care for HIV, elderly communities, so on and so forth, and we're willing to replace those tests for free if they're used, you're going to start to get results from the community that will serve as a signal if we start to see an uptick in cases. So I really do think it's important for us to address not just the access, pricing, and issues around the drugs, but also self-testing, and really, to Serge's point, focus on patients in communities who are truly at high risk and that we're going to need to get to quickly. So Chai's been a proud partner of the Quick Start program. In a number of low middle income countries, we're providing technical assistance to governments to establish the protocols, training, and logistics to support test and treat programs. I'm going to fully admit that, despite our name Quick Start, this is not as fast as anybody would like. And the quantities that we are able to provide at this point are not of the magnitude we need to. The programs are using small quantities of donated Paxlovid from Pfizer, or in some cases where product has been procured by Global Fund. But in order for these programs to sustain, they're going to have to be able to transition quickly to a low cost and easy access to treatment drugs. And so, Javier, I'll pick up on some of your questions in a moment. I'll note that 4 countries have received drugs at this point. The quantities are not huge, but we are now up and running and seeing, in at least 2 of those countries, patients being diagnosed and treatments being provided to those at risk. While we're online in 2 countries with product now in 4, this is a much broader effort, and we hope to have several other countries online quickly. The bottom line, I think, from what we've heard is we expect demand to change as patients begin to understand that a positive test result can actually result in a positive response in terms of their treatment. Treatments now exist. The treatments will make you feel better. They'll reduce your risk. But again, as I noted, it's very closely tied to the access to self-testing and those patients' ability to test themselves on a regular basis. Demand volumes are pretty low right now. Countries are actively planning for future through Global Fund's C19RM mechanism, which has quite a bit of resource available for test and treat and pandemic preparedness programs. But as noted, the quantification is exceptionally difficult given the dynamic nature of the pandemic. And so we need to think about schemes where, we deploy either a stockpile or what we traditionally term a volume guarantee. I think more modestly, our perspective is that even some very specific volume purchase commitments will help incentivize generic suppliers to really see a path to making it to the market and beginning to sell their products at scale. With regard to that $25 price, we can talk about that a bit more. I think, we would need to see a real market develop with demand in order to see the pricing come down further and, realize that there's a chicken and egg issue that, collectively we would need to solve in order to bridge the gap between the lower demand at $25 and, what we could see if we get to a truly high volume market.
Thank you, David. Thank you. I will invite now our audience to submit questions to our panelists. And while we actually get all the questions through YouTube, Twitter, or LinkedIn, I just wanted to reflect a bit on what you just said, David, about it is very important to have self-testing. And just wanted to see whether there's been any progress in any country on identifying those high-risk populations. So first, let's hear from Dr. Serge about the situation in Côte d'Ivoire, and then I'll get back to you, Carol and David, on that question. So Dr. Serge, any progress on self-testing, any progress on identifying high-risk populations and giving them self-tests as part of these pilot programs, or not really? What's your take on that? Over to you.
Merci beaucoup.
Thank you very much. So no, we have not distributed self-tests. So self-tests are not available for the big audience. They are only for people who buy them at the pharmacies. We never send them to the community. Self-test is a privilege for the individual. And we have the HIV model. So I'm speaking not about Côte d'Ivoire, but in general, and what I know from my colleagues from other African countries. So WHO asked for an antigenic test available. And I'm insisting the test is done by the nose. So for us, the self-test is not something that we have distributed. So we are doing, for example, the rapid test. So once we lose our taste, our smell, then the symptoms changed. So we need to adapt our response. And what I was telling everyone in Côte d'Ivoire is to do an antigenic test for everyone who's feeling bad, who's feeling sick, as we do with the malaria test, for example. The issue is that we should say that every person who's positive should have access to a treatment, but that is not true. You only have treatment if you have a comorbidity, if you are at risk, if you have diabetes or you are living with HIV. But the person who's living with HIV doesn't tell us all the time when they come to the health center. So that's where the difficult part comes in. So the challenge is to know if that person has diabetes or obesity. We don't have these data. So how can we quantify if we don't know the reality of these at-risk population? The best population or the best comorbidity we know is the persons that are living with HIV. But it's not the same for other comorbidities. So it would have been interesting if we did an analysis to ask ourselves, how can we improve these testing methods in this now new period, which is this endemic disease period that is coming? So that's what's missing. We need to understand how to adapt our response and make sure it's adapted to the context. Thank you very much.
Thank you, Dr. Serge. Carol, any reflection on the self-testing angle?
Yeah, no, thank you, Javier. I think self-testing is something that's still very important. It's the idea of bringing, these tests as close to the community as possible. And when we're trying to figure out these service delivery models and how it can be done, I think here, it can be done in private pharmacies or distributed in ways. And I know that a lot of the test to treat countries that we are working in, they are, it's in their guidance, but I think it's still hard to get actual true self-testing to be implemented. A lot of them are, just using as rapid diagnostic tests, in health facilities. But supporting them through self-testing, I think is important. I think clients have the ability and the self-efficacy to be able to identify when and if they need a self-test in order to see if they are infected and again whether they are at high risk and should be seeking treatment. I think we need to empower our communities and empower our clients to be able to do that. And we can, and they can do this. I think we need to just have the commodities there to enable them to be able to test, for themselves. We've done this with a lot of other models. HIV self-testing is something that can be very similar. It works, and communities do come in. It's a screening tool in the beginning, but then they come in and get the full diagnosis. This is specifically for HIV. I think for COVID, I think if you're tested positive out in the community through a self-test, I think that is can be seen as an official diagnosis. And if they need the treatment, they can. So I think one thing that would be important is to be able to have the commodities available and roll it out and create the policy environment that will enable the global access for this.
Thank you, Carol. David, any reflection on what Dr. Serge just said about the appropriateness of self-testing and the appropriateness of the current tests that we have?
Yeah, first off, I want to say I think the global guidance was slow with regard to the importance of self-testing, and therefore sending a signal, getting fast regulatory approvals for a variety of self-tests. We should really be targeting an expectation that these self-tests are at an equivalent cost to other rapid and self-tests out there. We see HIV self-tests available for $1 or less. We need to address those issues of equity which were raised. I think the national level policy has followed the slower guidance. And I really take the point that right now, in a way, self-testing is a privilege for those who are able to afford it. And it's not just LMICs. I live in a country where, you have to choose to buy self-tests. And it's not insubstantial. So, those who choose that privilege get it. It's not a public health program as it's being run. Now, that said, we're not seeing great progress in a lot of countries. And I think, today's discussion has highlighted that. We see a few countries conducting validation and verification studies on the approach. South Africa does have it in their testing policy. I would hope that at least for those programs where we have funding sources, specifically HIV and TB programs, countries are considering putting self-testing into their C19RM funding plans, because this is a tool which we're deploying in the case of HIV epidemic, and it seems appropriate that in specific communities at high risk that we are deploying them. So, just sort of some thoughts on a path forward that countries could choose if they find it appropriate.
Thank you, David. We just got a question for you, Carol, in terms of how USAID is, dealing with oral antivirals in relation to other COVID countermeasures, especially COVID vaccines. So has any of the two products being prioritized, or is it separate programs? And also in relation to the HIV and TB programs. So if you can, please let us know what USAID's position on this has been. Thank you. Over to you.
Sure. I think to answer your first question, we've been at least, not specifically just to USAID, but, U.S. government overall has been supporting the deployment of vaccines and helping to ensure global access to vaccines. I think that is an important medical countermeasure. I think prevention is key and first and foremost. But, I think at the same time, we are also supporting COVID oral antivirals rollout. This creates another layer another tool that is needed, among clients who are either not vaccinated and again, among those who are at high risk, highly vulnerable. Clients, despite vaccination, can still get infected. And so those who are, I think it's important that we have another tool to be able to support with these COVID oral antivirals. And as I mentioned before, these COVID oral antivirals have been shown to prevent hospitalization and deaths. I know that the clinical trials were initially among those who were unvaccinated. But, a lot of observational studies in various geographies have shown that benefit and positive impact in preventing deaths at really high risk, populations, those who are greater than 65, even, and really you see that increased benefit among those who are elderly. And so I think that is important for us to consider. I think we are, of course, rolling out among PLHIV. They are at increased risk for severe disease, and that risk significantly increases among those with advanced HIV disease, those who are populations. I think we are really supporting.
I think we lost Carol for a bit. Can you hear me well? Yes, okay. So while she comes back, David, there's a question for you on the pilot programs, and are you embedding studies to solve some of the gaps, the knowledge gaps that Janine and Morgan identified at the beginning of the presentation in relation to, effectiveness and cost effectiveness and things like that, or not? Over to you.
So we are doing our best to employ an approach which in the HIV space we've called enhanced surveillance, where really what we're focused on is a programmatic deployment approach with as much study of as many factors as possible in doing so. We are not, however, looking at running, clinical types of studies. They're looking at some of the efficacy questions which were raised earlier. We're considering those as asked and answered or appropriate for other situations. And we're more focused on studying the operational issues, which will lead to more effective rollout. With regard to cost effectiveness, it's a really good question. I think, clearly the effectiveness of the treatments in certain vulnerable populations is critical in order to be able to measure that. And we are not specifically as a program setting out to come up with a number in terms of cost effectiveness. But we are trying to embed as much research as possible. And, I think we'd be open to discussions with partners who are interested in whether there's more we can learn from the data and experience we're getting in implementing these programs.
Okay, well, thank you very much for that. I think we're coming to the end, and just wanted to give you all the opportunity to reflect on the future, and we'll actually give you the opportunity to tell us what you think the role of oral antivirals should be going forward, and if you could, make one policy, implement a policy to improve the current situation, what that policy will be. Dr. Serge, do you want to start? Over to you.
Okay,
I would like to thank everybody again. And before my final word, I would like to remind that before the HIV test, we did a treat-all. That was it, with a participation where I was the main investigator. This allowed us to fight for all types of HIV patients with the testing and treat all, allowed us to test here. We need to have treat all, because I cannot accept to have somebody who is a doctor who wants to get the antiviral. He is not going to respect this, and he's going to continue transmitting. The other point is that we need to put in context what we're going to do, understanding that our countries have to accept that COVID remains a priority. They don't even have a priority as vaccination right now. They don't have the testing, the tracing as a priority. They don't have as a priority looking for patients who are at high risk. If we continue like this, we're going to fail, because the population HIV is already really well constituted as an association for them. For the rest, no. So as a practitioner, I want to have these molecules as a pragmatic rule for COVID. I wish to have the arguments to convince my governments and institutions to accept, to make an extra effort for the near future. And our effort is on surveillance to see what the trends are going to be, and see the genomic also. So my advice would be, if I may, is not investigation, but to see in each country what the situation is. If we don't have that investigation, we don't have the elements. We have too many unknown factors. We need to have that in-depth study to be able to obtain the answers we're looking for. I thank you very much for your attention.
Thank you very much, Dr. Serge. Carol, what are your final words about the future and the policy intervention that should be put in place?
Yeah, no, thank you, Javier, and apologies that my internet hasn't been working too well today. So I think two things, I think coming for, I really do appreciate the global community with increasing global access, doing a lot of market shaping work. But I think from our experience, USA Test to Treat programs haven't been fully able to be implemented. And what I mean by that is getting hands into, getting drugs into the hands of clients, is because there's drugs are not yet, they're yet to arrive in the country. The reason for this was some procurement challenges with novel medications under emergency use authorization. This was because these products were under EUA. They're still considered investigation under US FDA laws. Originator companies provided very limited liability and indemnification, and what I mean by that is like protection from third-party lawsuits. And this resulted in prolonged contract negotiations, especially for USAID. And our procurement agents just couldn't come to an agreement. No one was willing to take on these risks. USAID was relying on the Global Fund to procure these oral antivirals, and they also experienced prolonged contract negotiations. So I think what we need to do is learn from this and find solutions or workarounds for our next emerging epidemic threat in order to allow for the rapid deployment and access of these novel medical countermeasures. I think we can do this as a global community, and figure this out. There should be no reason why, we can't get these life-saving, effective treatments and drugs to clients because of issues like liability and indemnification. I know that, COVAX, created a no-fault compensation program for eligible clients who suffer from serious adverse events after receiving a COVID vaccine. And so perhaps, some kind of no-fault compensation similar to that, can be created for novel medical countermeasures. And then finally, I think the second thing I wanted to say is, I talked already about community sensitization, but it's really important to get, to educate also health providers and medical decision makers. I think what we are learning as we're trying to roll out COVID oral antivirals is that there's a lot of misinformation or not fully understanding how some of these treatments work. I understand that there's drug-drug interactions with Paxlovid. I think that was presented earlier today. It's true there are significant severe drug-drug interactions with Paxlovid, but this is not insurmountable. This is a challenge that can be overcome. We can easily stop some of these interactive meds for 5 days. Some others, we're hearing from our experience that countries are requiring pre-treatment labs like LFTs or renal function tests. And in the end, these are not necessary. It's another layer that prevents access. And then finally, there is a very small, it's a very theoretical risk that, the ritonavir component of Paxlovid is can cause drug resistance among PLHIV who are not yet on ART or unaware of their HIV status. Again, this is theoretical, and in the opinion of expert bodies like the Infectious Disease Society of America and the HIV Medicine Association, this is extremely low. So therefore, I think accurate information, education, training must also be provided to health providers and medical decision makers. And so I'll end with that. Thank you.
Thank you, Carol. David, over to you.
Yeah, and I think, I heard in your question a look toward the future for future pandemics. I can't really explain it, but I don't think with COVID we ever saw the urgency around access to therapeutics that matched the urgency we saw in the community to get access to diagnostics and ultimately to vaccines. And I think, we need to think about why was that. Secondly, I think for developing pandemics, we know that you can see the worst before you have the perfect evidence as to what you need to do. If we could do COVID over again, the best time to have access to the therapeutics would have been as quickly as possible after the pandemic became known. We haven't talked about it, but I believe there was a massive global failure around remdesivir, which is another antiviral for which there was no urgency or even consensus as to whether, at a minimum, it would do no harm and potentially could do a lot of good. So I think we really need to think about, for future pandemics, now that we have a variety of antivirals on the shelf, how do we determine when sufficient evidence that we're going to, at a minimum, do no harm and we see some potential benefit, we're able to move a lot more quickly and with greater urgency around the therapeutic component of response.
And your policy intervention now?
I think we need to think about what is the guideline process going to be in a fast-moving situation like that, and question whether the guideline process we use, which requires, high quality RCT evidence, is the correct bar to use for a very early response within the outbreak of a new pandemic.
Okay. Well, thank you very much. I guess for me, I think my main reflection is we've missed the boat. Unfortunately, we didn't deploy the oral antivirals when they were most needed. And of course, they still have a role to play. We heard that that role is not globally the same. It has to be context specific. It has to be targeted. And we heard about the importance of this targeting. David alluded to HIV patients, TB patients, and also the importance of a package of services. So it's not just vaccines, but it's not just antivirals, but vaccines and diagnostics. Finally, I think it is not. This is a repeated game, so there's a lot we need to learn from this experience. We heard about in the liability and indemnification protection. We heard about guideline development. We heard about regulation. Heard about the importance of preparing for the next wave or the next variant, but also the next pandemic. So clearly, there's a lot of work that needs to be done to understand the best way to deploy these oral antivirals. So thank you all very much for your participation today. It's been a great conversation. Thanks to our panelists, to our audience, and we'll be in touch again. Have a good day. Have a good evening. Bye-bye.